Hello, my name is David Miller. I'm a dermatologist and medical oncologist at Massachusetts General Hospital. It is my great pleasure to be joined by Dr. Omid Ahmed, who is the co-director of the Cutaneous Malignancy Program at Cedars-Sinai Cancer Center, as well as the chief of research for immuno-oncology at the Angeles Clinic and Research Institute at Cedars-Sinai. Welcome, Omid.
Thanks, David. It's great to be here and to discuss this topic.
Today, we will be exploring the clinical impact of approved and emerged combinations in the advanced melanoma treatment landscape. In this first session, we will be evaluating the guideline recommendations for the immunotherapeutic approach to advanced melanoma. Currently, there remains a number of therapeutic options that would be reasonable to select as first-line therapy for advanced melanoma. These include monotherapy with the anti-PD-1 monoclonal antibodies pembrolizumab or nivolumab, combined immune checkpoint blockade with nivolumab plus either the anti-CTLA-4 monoclonal antibody ipilimumab or the anti-LAG-3 monoclonal antibody relatlimab RNBW, as well as the combination BRAF V600 mutation-directed agents such as dabrafenib plus trametinib, vemurafenib plus cobimetinib, and encorafenib plus the MEK inhibitor binimetinib. Briefly, we're going to focus on some of the landmark studies in regards to immunotherapeutic approaches, as these remain the most broadly applicable strategies to patients with advanced disease. If we look at the landmark studies, Keynote 006, Checkmate 067, and now Relativity 047, we see impressive response rates with monotherapy anti-PD-1 and perhaps even more efficacy with combination therapy. In general, we're starting to see a signal where combination therapy may be more efficacious for patients. But before we move on, Omi, what are your general thoughts about these data?
Well, David, I think it's interesting that over the last decade, we've been successful in finding multiple single agent and combination options for our patients with metastatic and locally advanced melanoma. What's come with this are questions about how to choose the best regimen, which regimen gives the best efficacy, and how to minimize toxicity while increasing the efficacy for our patients.
Great comments. Thank you. In the next session, Dr. Ahmed will discuss the rationale for why we may consider combining anti-PD-1 with the anti-LAG-3 monoclonal antibodies.